Hello, thank you. Welcome to joining us for DDU teaching. We'll start off with case number 1. And Ravi, thank you very, very much for starting this one. We'll start again. So let me know when you want me to continue.
Yeah. Describe the regional wall motion abnormalities. What coronary artery most likely is blocked? So this is the parasternal long axis view, which is showing basal and mid anteroseptal and basal and mid inferolateral walls. And they're thickening more than 50%, so I don't see any abnormalities in this view. And this is parasternal short axis at the papillary level. And I can see so hypokinetic anterolateral wall. This is mid anterolateral wall, anterior, anteroseptal, inferoseptal, inferior, and inferolateral are contracting well. This anterolateral is hypokinetic. So this is apical four-chamber view, which shows the anterolateral and inferoseptal walls. So basal inferoseptal is almost dyskinetic because it's going in opposite to the direction during contraction. And the inferoseptal wall also appears a bit thinned out. Apical wall is contracting well. Even basal anterolateral wall appears slightly hypokinetic.
Happy to move on?
Yeah. So apical two-chamber view, which is showing anterior and inferior walls. Stopped.
Oh, sorry. I hope it doesn't do that too much. Excuse me.
So this seems to be the anterior and inferior wall seem to be contracting well here.
Can you move on? Yeah.
Next one. Next one. So apical three-chamber view, again, this is showing anteroseptal inferolateral walls.
Any regional wall?
So the basal anteroseptal appears hypo. I don't know whether that's a tethered motion, but it appears dyskinetic. Basal anteroseptal.
Well, I think, okay, so you want to put that all together for me, please?
Putting all together, there was mid anterolateral, basal inferoseptal, and basal anteroseptal. They don't fit in one territory. I'm not sure, Sam.
So let's go through it. So this is a real patient that we had, and I guess I think it's really hard regional wall. Out of everything that we do, it's probably one of the most subjective things. The most important thing to get through in this case, and where I put it in, is just you know your walls, and that's perfect because you're going to be asked about them. It's something that the examiners get very touchy about if you don't get it right. And we have sort of got a high level of saying that if people don't get the walls right, that they might fail the case. So you got all your walls right. You said those with confidence. That's great. Some of the questions that we'd ask then is going to be acute versus chronic ischemia. So how do you tell the difference between acute versus a chronic ischemia?
One of the things will be in chronic, the wall will be thinned out, scarred, very bright. So that would suggest a chronic.
Very nice, very nice. And so acute contralaterally might be someone who's got normal thickness walls with some akinesis or hypokinesis.
Yeah.
And I think that's what's challenging about this case. I think we're dealing with some acute and some chronic changes. On this one, I think the posterior wall is much thinner than the septal wall, right? So this anteroseptal wall must be about, I think probably that's not the wall. This wall is here. So it's about, 11, 12 millimeters. I think this back wall is about 5. And I think it's not thickening quite as much as this wall, which is thickening. And again, I don't think it's to be pass or fail, but it's certain. I would have called this being hypokinetic at the back and potentially chronic.
Okay.
When we start to have a look at this, again, it's the clock face idea. You called the anterolateral mid-segment here, called this hypokinetic. Again, I think it's probably the infralateral and inferior areas and maybe the infraseptal as well, that are the areas that are decreased. Which brings me on to the reporting for, if you think that these segments are hypokinetic, when I ask for regional wall, let's not forget to talk about the RV. The RV, of course, has got coronary blood supply, and it's going to be affected, particularly if you've got inferior type changes. I think the RV is showing some maybe subtle signs here of hasn't quite got that bellows function in there, and that RV function potentially might be slightly down. But again, it is subtle and it's not pass fail or anything here. Here you picked up the infraseptal here, which you called slightly hypokinetic, and I'm sure you won't mind if I jump down your throat on that one, because it's either hypokinetic or it isn't. And so the slightly hypokinetic, again, this is not pass or fail, but again, just for the tightness of the language. And that's what's really important for the exam, is trying to make sure that we're tight with our language.
Would you say it is a dyskinetic, Sam, or?
Yeah, good call. I probably wouldn't jump up down. I would certainly wouldn't argue with that. It's just a big jump to go from hypokinetic to dyskinetic. Obviously, maybe we'd say akinetic in there. I think there's probably some tethering going on, but I again, not pass or fail. And I'm sure if you asked all of us online here, we're all probably going to give slightly different answers. But the importance is to pick up that there is a regional wall motion abnormality, but these aren't the most brilliant images in the world. That right ventricle, is it normal? I think it could be mildly down to my eye. That looks mildly impaired. And again, this is kind of fitting with that regional wall we saw on the other side. This one, again, anterior, comparing it to inferior, you got your wall straight on. You talked about the apical segment not having any regional wall. The one little comment I'd put on for the expert candidate who's sitting in here is to recognize that we are probably foreshortening this image. You can see the top part of that apex moving down towards the base, which tells us that we're not probably imaging from the true apex. That means we can overestimate the regional wall motion abnormality in that section. But for me, I thought that the mid and the inferior here the mid and the basal segments of the inferior wall here were hypokinetic. And the same here with the infraseptal, a second bite at the cherry of the infraseptal wall. So I guess it's probably a tricky case. It's not the one that's going to come up in the exam, sort of probably, pass or fail, talking about which areas. What I was sort of hoping that we'd be trying to see is the inferior area, inferior, infraseptal, infralateral, or hypokinetic. That RV looks mildly impaired. And for me, which coronary artery would that be then?
Right coronary.
Yeah, it could be right coronary, it could be circ. And this would be in keeping with someone who is obviously needing an inpatient angiogram at some stage. Doesn't have to be urgent, but was thinking that this did indeed show signs of some regional wall motion abnormality. So I think so summary, I think probably getting regional wall pass or fail is going to be a bit tough because there's a huge subjectivity to it. You've got to know about the so know your walls, which I thought you described very well. We're going to have to talk about the we have to talk about segments matching up with each other. So one of the things I was going to ask you is, if you think the anterolateral wall is down, which view do you have to look at? And that would be the the four chamber. Other views possible, the other views possible, talking about the subcostal short axis could be a nice one for the exam. There's another tip and trick, and just some of those sort of expert things. If I ask you about, tell me some, what other views do you want? Bring in some of those subcostal short axis. Talk about some of the caveats, like seeing that apex moving down. If you're off axis, you can overestimate the regional wall. Things like that. Okay. Rakesh, you happy to take on this one? Let me know when you want me to move forward. Oh, you're on mute. You okay for me to move forward? Cool.
Looking at the optical four-chamber view and the color Doppler as well. We'll first talk about the 2D view. The depth is not appropriate, so we're cutting the left atrium a little bit. What we are looking for is a patient in shock, and the LV seems to be contracting well, and the RV is contracting well. The mitral valve is coapting well. She did have a non-STEMI, so to comment about, not able to see the walls very well to comment about region wall motion, but grossly they look all right on the 2D view. Looking at the color Doppler, don't see any MR there, but there seems to be some turbulence in the LVOT. So wonder if there is any LVOT obstruction. That's the reason for what's going on. I would like to see more views in this, but I don't see any cross yet. There we go. So that's the continuous wave Doppler across LVOT. And we looking at the dagger-shaped acceleration of the color Doppler.
What was the Doppler? Sorry, I missed it.
So continuous wave Doppler
Thank you very much. Sorry,
across the aortic valve. So we can see that there is acceleration across the LVOT, and there are two peaks, so this could either be an aortic stenosis or it could be an LVOT obstruction. In this case, I would think more of LVOT obstruction, given that the 2D valve didn't look grossly wrong, and there was some flow acceleration.
What else could the two peaks be? So it could be LVOT or aortic stenosis. Could it be anything else?
If there's MR, then we could be tracing the MR jet as one of the peaks, and the other one could be the LVOT. I mean, the aortic. In this case, I think.
Sorry, I interrupted you.
Sorry, I mean, I think this is acceleration across the LVOT and not MR, and we're looking at LVOT obstruction.
Excellent. Okay. And so, how would you want to further interrogate it?
So if we can go back to, so for LVOT obstruction, we could look at 2D in the parasternal long axis and put an M mode across the LVOT, which would give us an idea about whether there is systolic anterior motion of the mitral valve. And that will give us an idea about whether there is SAM to go with the LVOT obstruction, and looking at flow acceleration and turbulence across the LVOT in the same view. In the apical four-chamber view, I mean, both in the parasternal and other views. We look at the aortic valve to look at whether there is aortic stenosis, to rule out aortic stenosis as a reason for these kind of Doppler images. Color Doppler image to look at the MR jet, which I didn't quite see on the color flow Doppler earlier, but it could still be possible if we may not be picking up a color flow Doppler. And to differentiate on the Doppler profile, continuous wave Doppler profile, the mitral regurgitation occurs throughout the cycle, while the aortic stenosis and LVOT obstruction Doppler phase, there is a gap between. I mean, the Doppler phase has a pause. There's a small interval gap after which it starts.
And what are the causes of the gap?
Not quite sure about that. Sorry.
You described this this one here that we've got marked as being LVOT obstruction. Could it be anything else? And I'm happy to go back and show you the 2D pictures again if you want.
Yeah. Is it like not LVOT? It could be mid cavity obstruction as well, because the acceleration.
And so how do you determine the site of the obstruction from here?
So we go to a pulse wave Doppler, and we look at the pulse wave Doppler from the LVOT and gradually move upwards.
Beautiful.
So we're looking at it here. So the first one on the left top is at the LVOT where you're getting aliasing, so and there is flow acceleration. And we are further going up in sequence. There is still aliasing there as well. So LVOT. So acceleration is reduced in the right bottom, and the left bottom also there is still about 1.5 meters per second. So somewhere in the LVOT and slightly before the LVOT is where the obstruction is.
And so what are the sites? So somewhere, yeah. So what were the sites again? So we got the LVOT obstruction and slightly before. So what's that called?
Yeah, it's not all the way to the mid cavity because the right bottom seems like the sample is close to the mid cavity, and there the acceleration is not much.
Yeah.
So it is between the LVOT and the mid cavity as well.
Yeah. Bagging out my pictures, that's okay. So I think you probably told me about this. So give me the possible etiologies of this pathology, therefore, that you're seeing.
So left ventricular hypertrophy, aortic stenosis, post TAVI, and hypovolemia and ischemia can also be a cause for LVOT obstruction.
Yeah, nice.
HOCM, HOCM.
Welcome. Yeah, very nice. And you could probably add in also it's probably not in this case, obviously, but maybe it's a bit of a crap question, but obviously you've got stress-induced cardiomyopathy in there as well. And if you've got right ventricle dilation with septal hypertrophy from hypertension. Yeah, good job. Man, you dug yourself out of that beautifully. I think that would have been maybe borderline pass, but there was a chance that you were going to fail that because the number of prompts I was giving you. So just like in like the hot cases in the fellowship exam, you expect candidates to be able to put this sort of question together. It's sometimes not completely obvious. You know, you're going to have some straightforward questions, no doubt. But there are also going to be some ones in there where we need to make you work and we need to make you, need to challenge you a little bit. And that's what sort of this afternoon's a little bit about, just to try and give you a bit of a nudge. And so you've got to try and be able to put things together. And if I show you a 2D picture and there's something in there which, you kind of pick up, that's going to be of relevance potentially later on in the case. In fact, if we're only allowed to give you, 5 slides or something is sort of the maximum we can do for a case, often we try and make sure that there's a thread that goes through and it kind of builds as it goes through. So that if you've got some findings in your first one, it's going to be of importance in the next slide potentially, okay? And one of the things that we can look at when we're seeing here is that you picked up the turbulence really nicely, and I could have probably prompted you a bit more, but that, we've got kissing ventricle sign, right? There's that ventricle doesn't look well filled. You could potentially argue that I'm off axis a bit. You can see that apex swinging down towards the base. So I may have foreshortened, but I think we're starting to see that there's some form of mid-ventricle turbulence in there as well. And that's what takes us onto this image. I think the aortic stenosis is not a bad call but again, I was sort of trying to get a little bit more. I mean, I think it could have been MR, but as you can see, it starts at the same time for both the obstructive gradient as well as the continuous wave Doppler trace in there. And so I guess talking about AS is okay, but you've got to give me more, because the normal thing that I'm showing you with LVOT obstruction is MR, right? So just get that language has got to be tight in there, that this is a slightly curly one, and it could be AS, could be MR, but I sort of had to prompt you a little bit to get to the MR. And normally that's what we see with the LVOT obstruction is MR, right? Because that's where it's pulling it forward. You've got an anteriorly directed jet, so you'd pick up both. But what's a bit weird is that they're both together, and so you actually correctly got it, so that it's a bit of aortic stenosis that's potentially in there. And then we've got to be talking about where the gradient is. And again, I had to sort of pull that from you a bit, but you got there, which is about the hypovolemia. And that's what these traces are meant to show, that you've got some form of LVOT obstruction because you've got aliasing just as you picked up. But as we scroll back with the pulse wave Doppler, and that's meant to be in the mid-ventricle, we're seeing we've still got a gradient in there suggesting signs of hypovolemia as well as LVOT obstruction. So just be wary of picking things up on the first image to then get it through onto the next one. But I think it would have been a pass. Oh, Rakesh. Prithvi, you good to go for the next one?
Yep.
Let me know when you're ready to go forward.
Okay. Yep. Okay. So to image mid-esophageal two-chamber view at 90 degrees. The main abnormality I can see is the LV systolic function seems to be quite hyperdynamic. And what I'm seeing here is prolapse of the anterior mitral leaflet with a lesion at the tip of the anterior mitral leaflet, which I'm not sure is probably a ruptured chordae. So with this anatomical abnormality, I would expect a severe mitral regurgitation as a cause of the hypotension. That is inconsistent with the LAD and the circ infarct. And the fact that the IABP was inserted in angiography suggests that that could have been possibly for coronary revascularization, post-coronary revascularization, but also for potentially a severe MR. So I would like to look at this in other views and apply a color Doppler across the mitral valve to see if there is a significant regurgitation. So we've got a color Doppler across the mitral valve showing patient is quite tachycardic. So that's a bit of a difficulty there, but still I can see possibly a severe mitral regurgitation. It's eccentric, anteriorly directed. There's a prominent flow convergence. I have to slow the image speed down to see the measure the vena contracta. But looking at the 2D anatomy and this, it was probably most likely to be a severe MR. And the other, yeah, so I'm seeing a significant amount of flow convergence and possibly a wide vena contracta of at least 0.7 or more. And how would I assess further severity of MR? I would, yeah, on color, I'm going to look at the presence of a prominent flow convergence and a wide vena contracta more than 0.7. I'll put a continuous wave Doppler across the mitral valve, and I would be expecting a dense, fully filled triangular continuous wave just that would suggest severity. I would be looking at pulse wave, and if my E velocity is more than 1.2 meter per second, that would suggest a severe MR. And also I would be trying to look, image the pulmonary veins to look for systolic flow reversal in the pulmonary veins. But also be looking for dilated left atrium and any downstream effects of the MR, such as pulmonary hypertension or right ventricular enlargement and dysfunction. So this, yeah, so it's hard to, so transgastric two-chamber view, showing the left ventricle and the right ventricle. Again, it's difficult because of the severe tachycardia. And difficult to visualize the pap muscles, but depending on the coronary arteries involved, I would guess that is probably the anterolateral papillary muscle that is involved, considering a LAD infarct. The septum also is quite thinned compared to the others, which would also be in keeping with possibly a LAD territory infarct.
You're quite correct. What's the most commonly affected papillary muscle leading to prolapse?
Normally, it would be the posteromedial because of the involvement of the right coronary.
Yeah, sorry,
or the circ.
Yeah, because the single blood supply.
Single blood supply of the
so it's pretty unusual to get the anterolateral, and I think you're absolutely right. I think that's what we're seeing here. And again, this would probably be a bit curly to stick into the exam, but I thought it was unusual, so I just wanted to show it to you. I know this is one of Chris Duncan's cases from a few weeks ago, and I just thought it was quite interesting because normally we don't see it. Nice. So that would have been a pass, and I think you could have done. I think you've done things really well in there. That assessment of the MR, that nice sort of systematic approach is great. Don't forget to talk about clinical signs and symptoms. Link it all back into there. I would have thought. You talk about how to assess severity in about a minute very nicely. That's just a nice, relatively easy thing to learn, which you did well. So 2 questions that we're going to commonly ask. So the first one is, how do you assess that? And then this, how do you assess it? Give us your overview on it in, 60 seconds. But the next one is also going to be about acute and chronic. And if you could have taken me to that, the idea of how do you do acute severe MR versus chronic MR, that could be in another question. And if if you're getting a vibe that that's what this question might be about, go for it, because often you might not see left atrial enlargement. You might not see the
acute Yeah, acute MR occurs suddenly, so the LA is unprepared.
Absolutely.
It's not dilated, so it's going to be an acute increase in left atrial pressures and acute pulmonary edema.
Very nice. The I guess the one that is often asked in the exam is talking about the acute versus chronic with aortic regurgitation, of course, as well. So that works for that one as well. So the only other thing I was going to add in, again, some of my favorites in there. You said that the LV was quite hyperdynamic, which is the well-known phrasing that I love. Again, it's hyperdynamic. It is or it isn't. You talked about the anterior mitral leaflet. Absolutely, but if you give me a little bit more, that's going to show your level of, understanding of anatomy. You could have given me maybe A2 in there as well. Give me the scallops. You said it was anterior, or ask for other views, but give me an idea. But I think at this level, it's often not pass or fail. To be honest, getting the scallops wrong is not going to cause you to fail. But it sure as hell is if you can come out with it. If you know it, you're relatively confident with it, bring it out. Often we ask about it. Trying to tell me if you know it, give it to me. The next one that kind of raised my ears up, you says, I'm not sure, but I think it's a ruptured chordae. And then you went on to say it's likely going to give you severe MR. I don't think, sorry. Man, that's not a chordae, that's a pat muscle, right? It's the side, it's bigger than it's bigger than the leaflet. So again, it's just the kind of things that just watch that relaxed language. There's think before you speak. A chordae is going to be a filamentous structure that's going to flick around. It's unlikely to be associated with severe MR, but I hadn't shown you too many other pictures. So, I think it's okay mentioning it, but that's a big ass lesion for a chordae. And with such a severe prolapse that we're seeing in there of A2, it's pretty punchy, I think. And the next thing to know, if we've got a ruptured chordae, it's got to have come from ischemia, right? Given the settings I just told you, this guy's had an infarct, right? And he's severely unwell in the ICU. He's tachycardic as all hell. Give me regional wall. There's why has this guy got it? You didn't talk to me about the regional wall, and I'd have thought that would stick in the setting of think broad. You got to think broad. Don't miss the regional wall. If I'm telling you about infarcts, tell me about regional wall. So again, just putting everything together. I gave that to you in the stem. I've given it to you here. It's not subtle. It's a massive papillary muscle rupture. Talk to me about regional wall. I don't think the regional wall is particularly obvious. Sometimes it isn't. But I think tell me about it. I think if it was more obvious, I'd have obviously given you a prompt. But I think on this one, you can see regional wall motion abnormalities. And again, you didn't tell me. You told me you thought it was anterolateral, which I completely agree. And then what I'd love to have heard was, because I can see there's probably some hypokinesis. It could be akinetic if it was able to be slowed down. The tachycardia gets in the way, obviously. But it appears that anterolateral wall is hypokinetic in keeping with the LAD territory, circ territory, and function. So again, just a few easy marks that would have been the difference between a pass and a pass well. And we'd have loved that. So good job. So and the last one was just there was a most likely probably severe MR. And again, just watch the language. I don't know if it gives other examiners the shits like it does me, but it's just again tight. Keep that language tight, clear, concise, extremely professional. One thing after another. Nice job. Juan, are you happy to do next?
Yes.
So this is a case that I was reporting earlier on this week, and I thought it might be worth bringing it up. So again, a little bit curly. Tell me when you're ready to go forward.
Didn't realize auscultation was part of neurobs.
It's just a holistic approach that we give in Nepean Hospital.
Very good.
I think it was the junior doctor that did it and put in the request. It wasn't actually me.
So yeah, we've got a parasternal long axis view. And nothing's jumping out at me. I mean, the RV potentially looks dilated, but obviously can't assess accurately from this image. I'll have to look at orthogonal views. The LV size, wall thickness, and global contractility appears normal. And again, with regards to the murmur, the question in hand, both the aortic valve and the mitral valve appear to be opening well. The leaflets appear thin and pliable. The atria looks normal size. Yeah. It's a lot of information here. So it's because the images, so obviously this the 2D image with overlay color flow is a apical 3-chamber, and that does appear to be
So that's meant to be the pulmonary valve. So we've just parasternal
pulmonary.
long axis view tilted up. We've got the pulmonary valve there.
Oh, okay,
And these
sorry.
are pulmonary valve flows.
Oh, that makes more sense. Okay. So PTI is acceptable. The pulmonary valve acceleration time is shortened, which obviously suggests increased pulmonary vascular resistance. There's no mid-systolic notch. Oh, sorry, apologies. There is mid-systolic notching of the pulse wave Doppler, further supporting theory that there's increased pulmonary vascular resistance, suspicion of pulmonary hypertension. So there's a so it looks like the RV inflow view. There seems to be an incomplete tricuspid regurg continuous wave Doppler waveform, and the I guess I'd have to question the accuracy of the measurements, but there appears to be the maximum velocity, the maximum TR velocity is 2.5, which with a pressure gradient of 26, which would be normal. So that goes against my theory of pulmonary hypertension. Again. So we've got parasternal short axis views, and the LV appears to be contracting well. The significant abnormality for me is that the RV looks very dilated and globular, and although this is not a classical view to assess RV size, it makes me worry. However, there's no other secondary features of pulmonary hypertension like interventricular septum shift towards the left. And here on this apical 4-chamber, we've got I'd probably say, yeah, so I'd say a severely dilated RV because it's apical forming, and it looks bigger than the LV. You can see that it's heavily trabeculated, even for the RV, and potentially. And so this makes me suspect RV right ventricular hypertrophy. Its longitudinal function appears to be preserved, but the radial contraction is probably mildly reduced. The RA looks probably dilated as well, though I'd like to measure the area to confirm this. I can't. So yes, I guess if there's pulmonary hypertension, so if there's increased pulmonary vascular resistance, makes me want to think, and with RV dysfunction, makes me want to think that there might be a intracardiac shunt. So
give me your conclusion.
Sorry.
So give me your conclusion. So put it all together. This was the last image. So put it all together for me.
Right. So yeah, this. So my conclusion, although this subcostal image is sort of of not diagnostic quality, my suspicion is that this patient has an interatrial septum with a left to right shunt.
Sorry, interatrial septum. So what did you say? Yeah, he's got an interatrial septum. You said. Can I just?
So interatrial shunt.
Very nice.
With a left to right shunt is what I meant to say. causing RV volume overload as evidence of the dilation and increased flow through the pulmonary circulation, causing increased pulmonary vascular resistance.
Great job, Juan. Great job. Man, you were bloody close. I mean, I think you told me before. You told me before that you thought the right atrium was dilated. I think having the left to right shunt. What color would the flow be if it was a left to right shunt?
I would be red.
Would be red. So I think
Yeah.
that's probably, I put that in there just to try and nudge you in that direction, and you got there all
Yeah.
by yourself on the slide before. That's fantastic. I mean, I think we've got unexplained right ventricle overload here. And absolutely, as you surmise, that we've got to therefore think about ASDs. So you did really well in that, and it was wonderful watching you squirm there. Thank you very much indeed. I enjoyed that very much. So completely. So we think we've got a murmur on auscultation. We've got no, guys, so I should have said he's got no past medical history that we're aware of. And very nicely, you pick up a generous size right ventricle in there. This number here of 97, I probably put you on a little bit of a wrong track with that. And, you know, this flying W sign, I'm not convinced about that, to be honest. I mean, I don't think there are major signs of pulmonary hypertension on this. You know, a acceleration time of 100 with a bit of a dodgy measurement, maybe. There's no horrible PR that we can see in there. There's no major TR. Maybe this is where the murmur was heard of. Who the hell knows? But there was no major things. But this guy's got an enormous right ventricle. And why the hell does a 32-year-old have an enormous right ventricle is really interesting, I think. And absolutely, you've picked up the idea right, which is what this sort of image is meant to try and push you towards, is does this guy have a shunt? I think this probably does not support the idea that he's got a shunt. But in conclusion, I'd have suggested that this guy needs to have a transesophageal echo at some stage to exclude a shunt. And if that is negative, then we need to work him up for pulmonary hypertension, which doesn't look severe based on the tricuspid regurgitation. But the etiology, as you said, ASDs at the top, and then thinking about weird pulmonary hypertension. But why we're not seeing any horrible TR is got to be investigated, and maybe that's just an imaging thing. Not bad, not bad. All right, chat.
Sorry, Sam, did you do a bubble study for that?
Yeah, great call. Yeah, absolutely. Sorry, we should have said we needed a bubble study. We did not have one routinely done. This was not something that was reported by the sonographer, unfortunately, which I was a bit surprised about. You know, I'm totally with Juan on this one. This was markedly abnormal for me, and the thing that made it markedly abnormal was that the short axis views. So I went through exactly the same thoughts as Juan was doing there. You know, everything was looking fine. I didn't even pick it up on the parasternal. I was just flicking through, you know, murmur, whatever. You know, everything's fine. And then this was the one that was like, hold on a minute, go back. Yeah, that looks generous. That looks generous in size. That looks freaking abnormal beyond all get up. Something funny is going on. And it's the trabeculation and the big size of the RV that obviously means that we need to go hunting. And he was meant to have a toe done yesterday, but unfortunately had something to eat before he got there. But we'll go investigate it. Yeah, nice one.
So just one more thing,
yeah, of course,
before we move on. The parasternal short axis views, would you say the septum, there is some septal flattening?
Yeah, I don't know about that. I mean, maybe, yeah. It's subtle if it is there, isn't it? It does look a little bit flattened, particularly in this mid-ventricle level. It's not horrific off the chart there. I certainly, it wouldn't have been a fail if you'd said yes to that one. I agree. Maybe, you know, I called it. I didn't think that there was a massive septal flattening there. You know, it doesn't seem to move too much, but I'd take your point. How about that?
Yep.
All right, chat-tastic. Go for this.
So a 56-year-old man in hospital, bradycardic arrest.
Oh, can I just quickly add something in? I've borrowed this off this. There's a file on my computer that I didn't do this study. I'm not entirely certain where it came from. And I just wanted to acknowledge that this isn't my study, and whoever did it, I thank them for it if this goes on the internet. But I can't remember where I got it from in my files, but it's a cracker. Sorry, carry on.
Past medical history, heart failure with reduced ejection fraction, vascular disease, BKA bilateral. Vessel disease, not amenable to surgery. Moderate catecholamine, stage 5, transthoracic echo performed for ongoing catecholamine needs after bradycardic arrest. Okay. So this parasternal long axis shows a number of abnormalities. And I just go sequentially. The left atrium is severely dilated. The mitral valve appears restricted in its opening, and the left ventricle appears severely impaired in systolic function. The infralateral wall is contracting, though hypokinetic. The anteroseptal wall is also hypokinetic. The aortic valve looks thickened and on 2D appears to be restricted, and I'm suspicious for aortic stenosis in this patient. The right ventricle within the limits of this study does not appear dilated, but I could be biased because the left atrium is so big. There's a trace pericardial effusion. So this is M mode through the aortic valve, and I can't see a normal aortic waveform there at all, which suggests that there is severe restriction in its opening and stenosis. The left atrium is dilated. So again, a zoomed up view of the aortic valve, and severe restriction, severe thickening, and bright white, I suspect, calcification. And with that history, I suspect it's going to be calcific aortic stenosis.
Which cusps are we looking at on this top left image?
You are looking at the non-coronary and the right or left coronary, the non-coronary and the left coronary cusp.
Just have another quick think about it.
I beg your pardon, it's the non-coronary and the right coronary cusps that we're looking at. I don't know why I said that. The color Doppler through the aortic valve shows high velocity through that aortic valve with several jets, suggesting a severely stenosed valve on color Doppler as well. The short axis through the same shows severely thickened calcific stenosed aortic valve with very little separation of the cusps. I do get the impression that it's a trileaflet cusp, although the separation between the right and left coronary cusp is not particularly clear, and I think a little bit of tilting of the probe would convince me otherwise. There is mitral regurgitation, a central jet, which looks on color Doppler to be moderate in nature at worst. It doesn't appear to hit the black wall. It is severely dilated. So where am I now? This is the tricuspid inflow. So this is tricuspid inflow, and there is what on color Doppler and continuous wave Doppler, severe tricuspid regurgitation with a completed triangular looking Doppler profile through that, and a dense envelope of regurg there. There's a vena contracta that looks wide. Going to the short axis and the four-chamber now, the right ventricle does appear dilated in this view. There is some flattening of the interventricular septum. Overall LV function remains severely impaired. There is global hypokinesis. I can't convince myself of a regional wall motion abnormality on the short axis. I think there's global hypokinesis of the left ventricle, and that's the anterolateral and infraseptal walls I'm looking at there.
Forgive me, did I miss the LV systolic function? Did you tell me that?
Yeah, I think overall LV systolic function is severely impaired. So this is looking at the mitral regurg. There is mitral regurgitation. It's an incomplete envelope and not a dense Doppler profile. So I think this is probably mild to I'm just going to pick one, moderate mitral regurgitation because of the degree of atrial enlargement. And I suspect the aortic stenosis is probably the bigger issue, as well as the impaired LV function.
Doppler trace tell you anything else?
The Doppler trace tells me that this, so the MR is going to be hard to interpret with an impaired LV, and
Right.
and so I suspect this severity of MR is also going to be complicated. Assessing its severity is going to be complicated by the severity of LV impairment that we're seeing. So this is the LVOT VTI at the top in the 3-chamber, apical 3-chamber. So the LVOT VTI is 12.3, so down, better than I thought it was going to be. The mean gradient is 1, Vmax is 0.7, DSI is 0.18, less than 0.25. Aortic valve area by continuity 0.61. Stroke volume, LVOT indexed, is less than 35, so 21. And this is the aortic valve VTI. Aortic valve continuous wave. I just need to move the box over. So Vmax is only 3.2, but looking at the calcium, the severity of the 2D appearance, I think this patient has severe aortic stenosis. The mean and the peak gradients are less than what I would expect, and I suspect this is due to their impaired left ventricular function. The dimension DSI is 0.21, less than 0.25 is severe, and the aortic valve area by VTI is 0.72. And so we're looking at a severe aortic stenosis in the setting of reduced ejection fraction, low flow, low gradient aortic stenosis. This is supported by the indexed stroke volume being less than 35, that we are looking at that same said thing. And I think this patient has got severe aortic stenosis.
Management. So how are you going to put
management of this patient is going to be extremely challenging, because I suspect this is extremely chronic and it's going to be hard to figure out what to do next. He is the kind of patient that could benefit from a dobutamine stress test, and so that would probably be the next step forward to see if we can demonstrate severe aortic stenosis, recruitability or no recruitability, which is they're already on a stress test. So this is severe aortic stenosis with limb. It's hard to know what the LV function was like before, but it's, yeah, it seems like there might be some recruitability given those gradients are impaired, but I'm still, the numbers are still leading me towards a severe diagnosis.
Yeah, nice. Just in the meaning of time, I won't go through this. This was all just about showing you, asking the severity of the tricuspid regurg. I think with a crappy RV, we're not getting a huge amount of TR. You probably wouldn't call that significant, but then you're meant to pick up here that you've got systolic flow reversal and picking up to be severe. I imagine you'd have all got that one. So let's just finish off that case and just chat. Hey, there were no there were no that was concise, that was tight language, that was beautiful cadence, that was going for the money first up. That was beautiful, chat. Great job. That was really nicely done, and that's great to see. Well done. I think my only comment's going to be, I think you said everything right there. That was a solid pass for me, and I think what might be worth doing is, we've done this a couple of times in some of the previous sessions, is to, if I showed you this, what am I going to ask you? And I think if you're reading through this stem, you can see this horrible vascular path with a history of heart failure. We're going to be looking at shitty LVs, in-hospital bradycardic arrests, What the hell's the cause for that? Ischemia, PEs, I don't know what we're going to show. The moderate catecholamine requirements, I think it's important to remember that you've got it in there. Doing an echo on day 5, I think trying to think about what I'm going to ask, and then just if you can remember that, as soon as I've shown this, and you straight away, you've got a crappy heart, you've got some form of valve disease with that aortic valve. You said restricted motion of the mitral valve. Why is it restricted?
Because the LV function's so poor.
Beautiful, nice. So I mean, just take me there, because again, simple things. That would have been a definite tick mark in there. That is the mitral valve the major valve abnormality here? No, it's going to be that. Almost lost me on the valves. Okay, can I just? We've actually got the two together. This might help with this to line it up. Okay, so if we go from the top left image and we rotate 90 degrees to get round to, with the marker pointed to the left shoulder, we get our short axis. And then if you can imagine, if you had a line down here, if you did biplane imaging, for example, you could get both of these images. And the biplane imaging would go straight down through the RV that you can see at the top there. And then it's either going to be the non or the left coronary cusp. So it's the right coronary cusp at the top and the left or the non-coronary cusp at the bottom. So because both of them go through the LA. So just again, that's again with the regional wall. Don't be sort of great with all that chat and then you fail the case because you said they were looking at the infrareceptal wall and it's the anteroceptal or something. Totally agree with that. Raised left atrial pressure from shithouse LV. That's probably underestimated. Then I think you said all that. Severe TR, very nice, triangular shape. Don't worry about that. That was all nice. This one. What else can you see on this trace? So we got a really slow rise of that mitral regurg.
Yeah.
And so potentially, what else could you show from that? If I just gave you that Doppler trace, you should be able to say, well, that's a DPDT waiting to be asked for. We've got a central regurgitation jet, which is why I showed you this one. We've got a cursor that's in nice orientation. Central jet is the kind of thing where we can, in sinus rhythm, is the kind of time when we can do the DPDT, which will be clearly in excess of, or clearly reduced there in less than 800, again, indicating we got a terrible left ventricle function. And then you got all this beautifully. Low stroke volume, low DSI, mean gradient is suggesting it's moderately impaired. And of course it's not, it's severely impaired based on the 2D features and the DSI. And we've got low flow, low gradient aortic stenosis. And then you had a brain fart and told me that he needed an exercise stress test. And of course he's having one. And then the key question for me in the last part of being about further management. I mean, do we palliate this guy? Well, no, we don't know what his heart was like before. Could it be stunned? Shit, I hope so. Otherwise he's buggered.
Yeah.
Nice. And maybe don't use the term buggered in the exam. Okay, who's next? So we got Drew. Do you want to go next one? Have we got anyone else who's doing the exam this year? Who have we got? Lucy. Lucy, you doing the exam this year, aren't you?
I'm not, no.
Oh, sorry, excuse me. Then don't worry, I will not hassle you. Drew,
No,
I know you're not doing the
that's
exam
fine.
either, but I'll hassle Drew instead. Excuse me.
I was almost saved there.
almost. This is a good one.
Almost.
This is great actually. This is again, I've put these in a slightly different order. I think this is a perfect case for you, this one, and this might finish up the session. We'll finish up with this one.
Goody, thank you. So this is a transesophageal echo. It's mid-esophageal view, short axis.
And what's the abnormality? We'll keep it punchy for this one. What's the abnormality?
The key abnormality is the severe right ventricular dysfunction.
Oh, yeah, good call. Maybe we can have a little bit of stuff there. Yeah, fair enough. Take that, not the RV dysfunction. That's not the case. I don't think it's off the charts, but it's a weird image. Give me another one.
The fixed systole intraatrial septal bowing, indicating a very markedly elevated left atrial pressures.
Beautiful.
This is it's an interrogation of the intraatrial septum. It's not exactly a bicaval, but it's just basically evaluating for the presence of a PFO. I wonder if the bubbles is actually a bubble study that's attempting to be performed.
Sorry, I should have said that. Yeah, it's a bubble study being performed. And what does it show?
So this indicates that there are bubbles. it'd be, I guess, useful to see the onset, determine how many cardiac cycles before the bubbles do enter the left side of the heart. But clearly there is evidence of a connection between the right atrium and the left atrium through.
Fair enough. Just I'm probably being a bit unfair here. So all this stuff you can see in the left atrium is this done from a Siemens toe probe, and Siemens often have they use quite high powers, I think, on their probes. And all this stuff that you can see in here is actually on other images there wouldn't be anything. So I don't think we are seeing connections going across. And this is just Siemens that makes often normal looking flows look like there's a bit of sec in there.
All right. Okay. Thank you. Well, in that case, there aren't any sort of bubbles that are passing through.
Do you think this guy's got a patent foramen ovale?
Look, there seems to be a 2D defect in between the secundum through the fossa ovalis region.
Yeah.
I can't be certain whether or not that crosses over into the left atrium, but I am a bit suspicious of that.
Yeah, very nice. So this is a big defect that we're seeing in here. So it's a really nice indication of the anatomy that you get with the septum primum and the septum secundum that come down, and this big hole there should not be there. So that's an example of there being a significant patent foramen ovale. But the weird thing is that we haven't seen these bubbles crossing from right to left,
because the high left atrial pressures
my man, fantastic. So when we put color on it, you can see as they breathe, you can see that there's this significant left to right atrial shunt, and it's again just trying to indicate that you've got to, when you're doing your bubble studies, you can have the most enormous patent foramen ovale, but when you're doing bubbles, they don't come over. And so what you're trying to pick up is this negative, negative contrast sign they sometimes call about it. I think it's, I use this as an example of how bloody difficult it is to try and pick up negative contrasts, but this is what one looks like. If you're having a look at it, this is what one looks like. They're not easy, and that's where you've got to use your color as well as your 2D appearance, as well as the bubble studies, obviously, and we'll go from there.
Do you think you'd have any luck with an abdominal compression or something like that, or like
it's not something I routinely do, actually. I think hearing from some of the guys that do structural work at Vinnie's, they were giving a talk, and one of the big things that they suggested was actually to put the cannula in the feet. So if you put the cannulas in the lower limbs, it comes up through the IVC, which means that it hits this thing here. What's that structure there? Oh, sorry, I don't know if it's
eustachian valve.
Very nice. Eustachian valve, eustachian ridge, and so that would direct it directly towards that foramen ovale that you can see quite nicely there. So it would go against that, and then you might see those bubbles a little bit easier. So they talk about using the legs would help maybe pick up that rather than
compression
pressing on their tummy. That's about it, I think. So we might just leave it there, and this will be my last session with you guys before the exam, and so I'm rooting for all of you guys. Thank you for turning up to these sessions. I think there are a couple more. I think Emma and Chris are taking the next two because I can't do the next two, and then I'll see you the week after for the exam. Best of luck to you all. I really hope it goes well.
Thank you very much, Sam, for all your help and support.
Pleasure.
Thank you, Sam.
Thank you, Sam.
Thanks, Sam. Good luck, everyone.
Yeah, here. And if you've got any questions, guys, please just give me a shout, okay? And you've got my phone number, or you've got my email address, and give me a call if there are any questions. And just best of luck with the last couple of weeks of revision.
If you learnt something, hit like and subscribe to our channel for more videos uploaded weekly.
For bite-sized versions, follow us on Twitter @EchoNepean and check out the tutorials.
Or head over to our websites for the latest hands-on courses. Links in the channel banner.
And thanks for watching.